Hi, I'm Andrew Penn. I'm a psychiatric nurse practitioner and an associate clinical professor in the UCSF School of Nursing. In these modules, we're going to be talking about anxiety disorders, a very common presentation in both outpatient and inpatient psychiatry. So this first module, we're going to talk about understanding some basic concepts in anxiety. Now, anxiety often presents as physical symptoms, so we'll talk about that and we'll understand the underlying wiring in the brain, which accounts for what we believe accounts for anxiety symptoms, and also discuss some medical conditions that can present as anxiety. So we're going to cover the parasympathetic and sympathetic nervous systems, which run in parallel. We're going to talk about the often confusing and overlapping anxiety diagnoses, and then again talk about things that can actually cause anxiety. So when we talk about anxiety, most people refer to that as sort of a physical experience as well as an internal mental experience. So things such as worry. But really, if we think about anxiety, it is largely a physical experience. And so that may take the form of muscle tension. It may take the form of tachycardia or needing to breathe more rapidly or more deeply, needing to go to the toilet, feeling weak and shaky, headache, sweatiness. And when we break these down, and of course, along with it come with these attendant cognitions that this cartoon sort of helps to remind us of. Because a lot of times what's happening is our body is setting off these symptoms and our brain is trying to make sense of it. And this is particularly true for panic. Now, if we take this idea that nothing in biology makes sense except in the light of evolution, we can start to understand how anxiety disorders reside in our body, if you will. And really we can, if you remember your autonomic nervous system anatomy and physiology, it's divided into two branches, the sympathetic, which is the fight or flight system, and then the parasympathetic, which is not only rest and digest, but also the freeze response, which is sort of the last ditch effort for survival when a organism is under threat. So when we think about the sympathetic nervous system, these are all things that evolved to help us survive being chased by a tiger, right? So we can break down all the different symptoms that occur in an anxious state and map them onto this sympathetic nervous system. So for example, we get tachycardic because we're going to need more blood to the muscles in order for us to run or fight. We might get nauseous, even throw up, or get diarrhea because what we're going to want to have in that moment is we're not going to prioritize blood flow to the gut to digest lunch. If we're being chased by a tiger, we're going to prioritize blood flow to the muscles. And so the body may just say, let's get rid of this food we're digesting, because if we survive this, we can eat later. Now on the parasympathetic side, we call that rest and digest. And this is where you see that sort of relaxation of physiology. You see the slowing of the heart rate. You see digestive activity. Interesting, you also see sexual arousal in that state too, because it sort of makes sense that we're probably not going to be interested in reproduction if our immediate survival needs are in question. So this is the rest, digest, and in extreme states, a freeze state. Now, it's often thought that anxiety disorders come about from maladaptive learning. Now, what do I mean by that? So this is where anxiety arises spontaneously or in response to a situation or like a threat. And we have both a mental experience of that and a somatic, or what's known as an interoceptive, an internal sensory experience of that anxiety. Now, what the brain tends to do is it tries to make sense out of that. So if our heart starts pounding and we get palpitations, we might get a cognition that tries to explain that. That says, oh no, I'm having a heart attack. And that, of course, amplifies the anxiety until it peaks and subsides. That's the normal occurrence of an anxious moment. So if you've ever had a near miss, say crossing the street and a car almost hits you, you definitely had that rapid response, that fight or flight response, and you might have had even like an angry outburst. You might have yelled at the car, and then afterwards the anxiety drops down and you return back to baseline. So that's sort of normal learning. But what happens in anxiety, we get into this anticipatory loop. So we start thinking, what if this happens again? Right? And then the understandable behavioral adaptation is to avoid anything that reminds us of that anxious stimuli, that frightening stimuli. And this is really at the heart of anxiety, is avoidance. And then if we avoid it and the thing doesn't happen, our brain takes that as, see, you dodged a bullet. If you had gone and crossed that street again, you would have gotten hit by a car. But since you didn't cross the street, you didn't get hit by a car. So we get this reinforcement aspect as well. And this is really what causes this sort of maladaptive learning process. And it actually serves to intensify the anxiety, because the more that we're not going out and doing the thing that makes us anxious, the more it's reinforced that the avoidance of that stimuli is what prevented harm from happening. And this is what kind of creates this downward spiral of intensified anxiety. And we go around and around where we go. I will often explain this to patients that, so we have this fight or flight wiring. Most people have heard of that. And I'll say, have you ever lived in a house where every time you made dinner, the smoke detector went off? Well, the parts of your brain that detect danger are like a smoke detector. But the problem is that every time you're having these panic attacks, say in the middle of your work day, it's your smoke detector going off when you're making dinner. That your house isn't actually on fire. You're not actually in any danger, but your brain doesn't quite understand that. And this wiring for anxiety lives largely in the limbic system, in the midbrain, in the center of that circle there. So these would be things like the amygdala and the hippocampus. And I think of the amygdala as really being like airport security for the brain. I'll say more about that in a moment. But also the thalamus is involved here, and the hippocampus, because the hippocampus is involved with rapid memory retrieval. So let me say more about this here. So really everything that comes in through the brain has to come in through the thalamus. So the thalamus is really the front door to the brain. So all sensory information, whether it's from the eyes, the skin, it doesn't matter. It's all going to come through the thalamus. It's gated through the thalamus. And so we think of this as sort of like airport security, right? Everything's got to come through there. And what's really airport security, what's really these guys doing the screening, is the amygdala. So every bit of information coming in through the thalamus is run past the amygdala. And the amygdala says, are you safe or are you dangerous, right? Now, if it's a known quantity, so you see me in the hallway, and I'm not registering as a threat, because your hippocampus is saying, oh, that's Andrew, we know him, he's our teacher, right? And the amygdala doesn't need to fire, right? So there's no alarm that goes off. Now let's change the situation, because when we think about airport security, the 99.9% of people coming through airport security are not a threat. So the airport security have this challenging task of trying to figure out who is the dangerous person out of this vast sea of non-dangerous people. So the same thing goes true for sensory input. The vast majority of our sensory input is benign, the things that we see in the course of a day, but your brain needs to be ready for that one time when you're crossing the street that car isn't going to stop for you in the crosswalk. So what does that look like? So we have that again, perception, thalamus, amygdala, right? But this time, instead of, so the airport security, they're kind of looking for threats, right? Knowing that the vast majority of people are not a threat. Oh, and here's this person that we've been looking for. Obviously, the slide's a little dated because he's dead now, but regardless, it works for the example. So in that moment, the hippocampus says, wait a second, that's the guy we've been looking for. And it sends a signal to the amygdala to set off the alarm. And the alarm takes the form of the sympathetic nervous system firing off. So now we're getting all the symptoms you would expect from a sympathetic nervous response. You're getting tachycardic, you're getting diaphoretic, you feel nauseous. All of the symptoms that you would expect in a fight or flight response are there. And so we can have internally generated anxiety, and that can come in the form of worry, what we now call in DSM generalized anxiety disorder. It can also come from panic, it can come from OCD. And GAD really is this sort of big bucket that captures a lot of these sort of not well described anxiety symptoms of usually physical tensions and physical symptoms and a mental aspect of worry. This is GAD was the replacement for neuroses in DSM-3, I believe. Neuroses and was comprised basically of GAD and what was later called dysthymia, and now is called pervasive or persistent depressive disorder. so kind of low-grade depression. But these were people that were sort of generally kind of tense and unhappy. But the thing about, if you open up the DSM, it looks like that there's these distinct categories of anxiety, and the reality is they are far more overlapping than the DSM would lead you to believe. So some people with GAD, but not all, will have panic attacks. Some subset of people with panic attacks will develop agoraphobia. So panic attacks are not actually a diagnosis per se, they're a symptom. Panic disorder is the fear of having a panic attack. And out of fear of having a panic attack, some people will develop agoraphobia, where they feel like, if I don't go out of the house, if I don't do things that feel scary, I won't have a panic attack. And so their lives become very small and constricted because of that fear of going out. Social phobia is another overlapping condition. Social anxiety is another name for that. OCD is thought to be a little more of a separate phenomenon. Most people with OCD have anxiety. Many people with anxiety don't have OCD. But it's certainly in the anxiety disorders category with some overlap. And of course, a lot of these folks have trauma, so we need to think about a trauma-informed diagnosis. Many people will try and address their symptoms of anxiety with alcohol, and so there is some overlap between anxiety disorders and alcohol use disorders. And then there's another subset of people who have what we might call distress intolerant personality styles that lead them into having a very anxious presentation. So these might be sort of avoidant personality disorders or borderline personality disorders. Sometimes these are people that get very anxious when they're under a lot of distress. And then of course we talk about depression and anxiety as if they are in two separate silos. And the clinical reality is that they are very overlapping. And so we see a huge comorbidity between anxiety and depression. And the direction of correlation can go in both directions, but it's pretty well known that people who have long-term anxiety can often become depressed because, frankly, it's kind of exhausting to be depressed, to be anxious all the time. But, you know, anxiety, I think of it as the bread and butter of our practice. It's really kind of the common cold of human beings when it comes to psychiatry. And that we see, you know, about a third of people will, a quarter to a third of people will have some diagnosable anxiety disorder at some point in their life. So this is incredibly common, and you'll see a lot of it in practice. And as I mentioned, anxiety can definitely predict depression. In fact, it's the single largest predictor of developing depression, and that overlap is about 50%. And GAD is the highest predictor of developing depression, followed by panic disorders. Now, in general, women are generally affected more than men in this. I do want to recognize that this is a bimodal way of looking at the world, and this does not capture gender variant folks. So I apologize for that, and this is just really a shortcoming of the data sets that we have at this point in time. So I'm hoping that as science goes forward, we have more nuanced data that really reflects the world that we live in. So women tend to have panic, GAD, social phobia, and PTSD at rates of about 2 to 1 over men. OCD appears to affect men and women about equally. And that anxiety tends to show up in the lifespan earlier than mood disorders. But GAD can certainly show up later, but often people will talk about having anxiety before they talk about having depression. And that GAD does tend to be somewhat persistent and can cause a lot of disability. So another good argument for treatment, whether that's pharmacological or psychotherapy. And another subset of patients who often struggle with anxiety are people with bipolar disorder. So bipolar disorder, again, about 50% of people with bipolar disorder have a diagnosable anxiety disorder. So it's almost so prevalent as to call it a symptom of bipolar disorder. But that said, about 50% of people with bipolar disorder do not have an anxiety disorder, but it is certainly higher than the general population in the bipolar population. And anxiety, as anybody who's ever worked in an emergency room can tell you, often presents with physical complaints. And so your big challenge when you're doing this workup is trying to decide how much medical workup do you need to do in order to feel confident that what you're actually dealing with is is anxiety and not a physical complaint, because many people walk into an ER saying, I have chest pain. And some of those people are having an MI. Some people are having a panic attack, and you need to be able to differentiate between the two. Now, you don't want to scare people unnecessarily. So when you're talking about having a medical workup, you want to talk about being thorough, making sure that you're not missing anything, but also not putting more fear into somebody who's already anxious. And telling them that essentially you're doing these, you want to explain that you're doing this workup in order to make sure that you're ruling out any real medical issues. Now, the most common things that cause an anxiety type presentation are, of course, cardiovascular. So arrhythmias are really common. You know, many people will get these, a couple of PVCs as a common side effect from caffeine, which will cause the heart to, you get a palpitation and you feel like, oh, what was that? That felt strange. And then, of course, you could pop that person on EKG right then and you wouldn't see anything because they're transient. AFib can certainly show up as an anxiety presentation. People who are anemic often will be tachycardic to try and compensate for their anemia, and that can lead to an anxiety type presentation. Hyperthyroidism is more common than I'd say hypothyroidism in mimicking anxiety, because you're going to have that excessive thyroid hormone coursing through the body, which will cause things like tachycardia. When people get hypoglycemic, often they become anxious. And then, of course, any of these electrolyte disturbances. Some people will get anxious when they're hyperthermic. They have this sort of panicked feeling like, I have to get out of this hot room. I have to cool off, which is adaptive, honestly. Pulmonary problems can also cause an anxiety presentation. When people get asthmatic, when they have a bronchodilation or bronchoconstriction, you can certainly have an anxious feeling of like, I can't breathe. And then people with more chronic pulmonary diseases, COPD as such, idiopathic pulmonary fibrosis, will often really struggle to breathe. And that tachypnea will lead to an anxiety kind of presentation. And then there are some odd ducts, like pheochromocytomas, are tumors that cause a big release of norepinephrine. They're very rare. Someday before my career is over, maybe I'll find one, but they can certainly cause a panic type of presentation. And then other neurological symptoms that can cause panic type symptoms. Vertigo, benign positional vertigo is probably one of the most common ones. I had this once, and I'm lying in bed suddenly and the room starts spinning and I'm feeling nauseous and I'm thinking, oh my God, what is happening? Am I having a stroke? What's going on? And it turns out I was just having benign positional vertigo. But you can see anxiety present in a number of different neurological presentations. Of course, obviously, anybody who's going into anaphylaxis is probably going to be terrified, which certainly makes sense. And then sometimes medication side effects can cause these sort of anxiety-like presentations. So akathisia is probably the most common one, where the person's given, say, a high-potency antipsychotic or is just starting on SSRI, and they get this kind of restless ants in their pants feeling like, I just can't sit still. And a lot of times the mental process that goes along with that will be an anxious one. And then corticosteroids, so like prednisone, is notorious for making people feel really ramped up and kind of anxious. So when you're making this differentiation, you got to think about a number of things. You want to think about what's the likelihood that this person is actually having a serious medical issue. So if you have a 70-year-old 2-pack-a-day smoking patient with cardiovascular disease sitting in front of you talking about chest pain, you better get an EKG and cardiac enzymes for sure. If it's a 20-year-old patient, you might get the EKG. If it's normal, you might feel more confident saying that it's anxiety, but you're probably not going to throw the whole kit and caboodle at them. And you're looking at what sort of medical history they already have, and you're looking for an organ system constellation. So, if somebody is telling you that they're having intermittent chest pain and their big toe is hurting, those two things really don't have a lot to do with each other. So it would be different than if they were having crushing chest pain, shortness of breath, and they were sweating, and their and their EKG is showing abnormalities. That obviously would be an organ system constellation. And of course, I'm always interested. I'll ask the person, oh, so when you get these chest pains, what happens if you go up a flight of stairs? What happens when you exercise? Because a cardiovascular presentation is more likely to be brought on by exertion. And then I'm also interested in how people responded to medication of different kinds, if that helps, because that helps you kind of understand if there is a physical component to it. Substances can certainly cause anxiety. Good old caffeine there is probably one of the biggest culprits. Some people will get very anxious on cannabis, and that's probably dose dependent. There may be certain genes that code for that. Some people will get anxious, especially as they're coming on to a psychedelic experience, or they can become anxious in the middle of it because of some of the possible distortions or distress that they might find themselves in. Nicotine, especially for people who don't have a tolerance. If you ever smoked a cigarette in your life, you might remember the first time you had nicotine. And it definitely is what we call sympathomimetic. So it triggers a sympathetic nervous system type response with tachycardia and such. And then it's common to see significant anxiety with alcohol withdrawal, especially while alcohol itself is often anxiolytic, it decreases anxiety. Alcohol withdrawal, you have this sort of revving up of all these systems that are normally kind of kept suppressed by regular alcohol consumption. And so you can see anxiety along with tachycardia, sweating, and things such as that. As I mentioned, stimulants, including caffeine, but of course cocaine and amphetamines can cause anxiety as well. And, you know, a lot of times it's really helpful to go over with a patient what their caffeine intake is like, because people often are consuming a lot more caffeine than they actually realize. And this gives you a ballpark idea of what's in different caffeinated drinks. So in summary, anxiety is this sort of perfect storm of physical symptoms and distressed cognitions that the person has around their physical symptoms. And there's a bidirectional relationship there. So if somebody starts thinking about something that's stressing them out, they can begin to show physical symptoms. So there's this anxiety is a great place where we realize that body and mind are not separate entities, that they are obviously one and the same. And we can think of these anxiety disorders as sort of maladaptive firing of the alarm system of the brain that was certainly useful for us in evolution and in avoiding threat. It's adaptive, but when it fires, you don't want your smoke detector going off in the middle of dinner. And that there is this challenge clinically of differentiating out the medical symptoms of anxiety presentations from actual physical pathology. And you want to make sure you do that before you feel confident that somebody is presenting with anxiety and not a physical complaint. So I hope this has been helpful, and in our next modules, we'll start talking about treatment options. Thanks.